coming to the next set of discussion, we are going to learn about the infections, okay, infections in the vagina. In the first picture, you are able to see that the patient is having a greenish color frothy discharge. So, this is going to be your, yes, very good, this is going to be a trichomoniasis vaginalis. And here you have a curdy white discharge in the vagina. So, this is going to be your candidiasis. And finally, here you have a whitish discharge which is very thin, okay, white thin discharge. So, this is going to be your bacterial vaginosis. Okay, so this is how you differentiate between the different types of discharge. Clear? Right. Now, we will see one by one. So, the first discharge is trichomoniasis vaginalis, which is caused by this organism, Trichomoniasis vaginalis. So, here the pH will be more than 4.5. As we have seen, the discharge will be foul smelling, somewhat yellowish in green color, and frothy as well. The patient will be presenting to us with pruritus, dysuria as well as dyspareunia. So, on speculum examination, you will be able to see something like this. So, this is called as strawberry cervix. Okay. And on investigation, while you give a saline microscopy, you will be able to see motile organisms itself. And when you take it for the culture, the media used will be Schwartz culture. And remember, trichomoniasis vaginalis is a sexually transmitted disease, and hence the partner should also be treated. Okay, so the drug of choice for treating trichomoniasis vaginalis is metronidazole. Clear? Right. Now, let's see this one. So, what are these cells? So, these cells are nothing but your clue cells, characteristic of your bacterial vaginosis. Okay, so clue cells, characteristic of bacterial vaginosis. Clue cells are nothing but the epithelial cells where the bacteria are adherent to these cells, right? So, these are seen in bacterial vaginosis. Now, talking about bacterial vaginosis in short, bacterial vaginosis is caused by Gardnerella vaginalis. Here also the pH is going to be more than 4.5. Already we have seen the discharge. The discharge is going to be very thin and white in color, and it also will be foul smelling. Okay, and in these patients there will not be any pruritus or erythema seen. Investigations, you can offer them saline microscopy where you will be able to see the clue cells. Okay, the bacteria are adherent to the epithelial cells. Okay, right. And the next one is, you have a special criteria for bacterial vaginosis, that is Amsel criteria. The pH is going to be more than 4.5. It is a grayish discharge usually, and clue cells are seen. Clue cells are not always present. Okay, so it will be seen only in 20% of the cases, but yeah, it is considered in the Amsel's criteria, and you should have your whiff test positive. So, whiff test positive means you will add 10% potassium hydroxide to the discharge. Okay, when you add potassium hydroxide to the discharge, it will be somewhat fishy in order. Okay, and gram staining can also be done where you can get a score called as Nugent score. The drug of choice for treatment of bacterial vaginosis is again metronidazole. Okay, yes. Now, let's talk about candidiasis. So, candidiasis This is most commonly caused by Candida albicans. Okay, caused by Candida albicans. You have to note that the pH of these infections are going to be less than 4.5, and there is no odor in the discharge, but these discharge are curdy and thick. There is increased pruritus in the discharge and dysuria. There is also erythema seen. Okay, on microscopy you will be able to see pseudo hyphae or spores. Culture will be done in a media, that is STA media, and the drug of choice for treating this condition is fluconazole. Clear? Right. Now, coming to the next set, we are going to study about the vaginal epithelial cells. Okay, we have the superficial, intermediate, parabasal and basal cells. Okay, so these are very important. So let's study about the superficial cell first. Okay, so how does the superficial cell look like? So superficial cell or the most mature cell of ectocervix. Okay, these are the most mature cells of ectocervix. And remember, these cells are mostly seen during the proliferative phase of the menstrual cycle. Proliferative phase is under the influence of which hormone? Estrogen. So, these are seen under the influence of estrogen hormone. These are usually polygonal cells. Okay, you are able to see that they are polygonal cells with abundant eosinophilic cytoplasm. They will also have small pycnotic nucleus and they will have keratohyalin granules as well. Okay, so this is a characteristic feature of superficial cells of the vagina. Okay, these are the most mature cells of ectocervix. They are mostly seen in the proliferative phase under the effect of estrogen hormone. They are polygonal cells with abundant eosinophilic cytoplasm. They have keratohyalin granules and they have a small pycnotic nucleus, right? And the next set of cells is intermediate cells. Okay, so intermediate cells are also polygonal in shape. They are also polygonal in shape. They have abundant bluish cytoplasm, and if you see, okay, this cell. So, if you see, these cells also have a nucleus which is larger and there is granular chromatin as well. Okay, and remember, these cells, intermediate cells, are seen during the second half of the cycle, that is secretory phase of the cycle, and the hormone acting here is, yes, progesterone. Clear? Right. Now, let's also see about the parabasal cells or the basal cells. These are immature squamous cells, parabasal cells. Okay, immature squamous cells, and the nucleus is larger. Okay, for example, if you see the nuclear cytoplasm ratio, this is going to be 1:2. Nucleus is going to have a vesicular pattern with fine reticular chromatin. Okay, and the cytoplasmic area is much smaller, right? Now, with the help of all the three types of cells, we will be calculating an index called as maturation index. Maturation index. Okay. So, this helps in quantifying the estrogen status of vaginal epithelium. Okay. So, this is basically written with the parabasal cell starting first, followed by the intermediate cell and then followed by the superficial cell. That is, you have to go from the base to the apex, right? So, parabasal cell, intermediate cell and then the superficial cell. Okay. In the reproductive age, that is in the reproductive age group, you will have a maturation index of 0, 70, 30. Okay. This means that the parabasal cells are few, okay, then superficial and intermediate cells are present. Since this is your intermediate cells which is predominant, that means there is more of progesterone action that is seen in the secretory phase of the menstruation. Clear? In menopause, you will have a score of 0, 80 by 20. Okay. So, what happens during menopause? Again, superficial cells. So, superficial and intermediate cells will become much smaller and they also reduce in their capacity. Okay. And in the late menopause, it may even turn as 100, 0, 0. Okay. So, that will become completely nil as well. Clear? Right. Next one is Bartholin's cyst. Okay, so you are able to see a Bartholin cyst. Remember, Bartholin cyst is something that is situated in the posterior half of the labia. Okay, so this is a Bartholin's cyst. Bartholin cyst is about 5 centimeter in size usually. Rarely it can be bigger also. Okay, so the content of Bartholin cyst is usually the secretion of Bartholin's gland, which will be a mucoid fluid. If there is any obstruction in the Bartholin gland duct, either due to infection or trauma, then this Bartholin cyst can form. The most common organism causing infection here is E. coli. And these patients are usually asymptomatic. Usually they are asymptomatic. And remember, the most common location of Bartholin cyst is right side and it is located in the posterior labia. So, how will you treat these patients? You will treat these patients by asking them about their symptoms. Okay, suppose the patients are asymptomatic and they have a less size of the cyst. For example, if it is less than 3 centimeter, then no treatment is necessary for them. Suppose it is more than or equal to 3 centimeters, then you will offer them incision and drainage. Suppose the cyst is infected and it has been converted into a Bartholin's abscess means, then definitely you will offer them incision and drainage. Okay, along with your antibiotics. Okay, so along with your antibiotics. Suppose if you have any recurrent Bartholin cyst or recurrent Bartholin's abscess, that time you will go for, yes, Marsupilization. Now, marsupilization is a procedure where you will be cut opening the skin that is present over the Bartholin cyst first. Then you will cut open the Bartholin cyst wall as such. Then you will drain the contents. After draining the contents, you will suture the skin under the cyst wall like this. Okay, so that the opening will be left out. If any collections that are coming from the Bartholin's gland will be let out continuously. It won't be allowed to collect inside. Okay, so this is a procedure of marsupilization, right? Now, yeah, one differentiating feature of Bartholin cyst is Gardner cyst. Remember, a Gardner cyst is an anterior vaginal wall cyst. Okay, so mostly if they give you a picture of Gardner cyst, check if there is any signs of vagina. So this is a vagina, right? So on the anterior vaginal wall, you have a cyst that is Gardner cyst. Whereas Bartholin cyst is not like that. Bartholin cyst will be situated in the posterior labia, mostly towards the right side. Either it can be a cyst or it can be an abscess, and it depends upon the other associated clinical features. In abscess, you will be having other clinical features like there was more pain, tenderness, fever, leukocytosis, like that. If any such history is given, then it will be a Bartholin's abscess. Clear? Right. Now, this procedure is nothing but your Burch-Kolpow suspension. Okay, Burch-Kolpow suspension procedure that is done for your stress urinary incontinence. Okay, so this is a mid-urethral procedure where the mid-urethra will be taken and it will be tied to the Cooper's ligament above. Okay. So this is Burch-Kolpow suspension that is done for stress urinary incontinence. Also, we have two more procedures. One is your TVT, that is transvaginal tape procedure, and TOT, that is transobturator tape procedure. Here in TVT, the tape will be placed through the space that is behind the pubic bone, that is will be passing through the retropubic space and will be placing the tape. Whereas in TOT, it will be placed, it will be taken through the sides of the groin and it will be placed in the obturator canal. Okay, so these are the other two procedures that are done for stress urinary incontinence. Clear? Right. Now, yes, so this one. So what is this test? Yes, this is a 3-swab test. Okay, a 3-swab test is used in case of fistulas, genital fistulas, to determine the type of fistula. Okay, so normally we'll take 3 pieces of cotton wool or gauze and keep it at 3 places. Okay, one is kept at the upper part of the vagina, other one is kept at the mid portion of vagina, and the other one is kept at the lower part of the introitus. Okay, near the introitus we are keeping it. Okay, in step 2, this is step 1. Okay, in step 2 we'll be instilling the bladder with a diluted solution of methylene blue dye, or we can also use indigo carmine dye through a catheter. Okay, then after this, the patient will be asked to walk for some 15 to 30 minutes. Okay, normally. After that, all the 3 swabs will be collected and will be tested. Now, how to interpret this test? Okay, so how to interpret this test? You will collect all the 3 swabs and you will check for whether it is stained by dye or urine. Suppose you see the lower swab being stained with dye, then the connection is going to be urethrovaginal. Okay, so this is a urethrovaginal fistula. Suppose if the middle one is soaked, then it is going to be a vesico-vaginal fistula. See the connection. Okay, this picture will help you. So this is a vesico-vaginal fistula. Now the upper one can be either a vesico-vaginal fistula itself, or it can be a uretrovaginal fistula. Okay, vesico-vaginal fistula means the connection can come like this. Okay, or it can be a uretrovaginal fistula. In case of vesicovaginal fistula, a higher vesicovaginal fistula, okay, it will be stained by, the upper one will also be stained by dye. Suppose if it is stained by urine, then the connection is between the vagina and the ureter. That is a ureterovaginal fistula. Clear? Right. So, vesicovaginal fistula. And suppose the upper one is stained, you have to check whether it is by a dye. If it is by a dye, it is going to be a high vesicovaginal fistula, and if it is going to be stained by urine, this is going to be a ureterovaginal fistula. Clear? So, this is a 3 swab test and how the test is interpreted. Now, in case of fistulas, you have to ask them another history also. If there is continuous leakage is seen or not. Okay, definitely they will say there is continuous leakage. And then you ask them, if continuous leakage is there, you are going for normal urination or not. You are normally voiding or not. So, if normal urination is present means, then it is going to be ureterovaginal fistula. Okay. Suppose if there is no normal urination is absent means, then it is going to be a vesicovaginal fistula. Okay. So, what is the most common cause of fistula in developing countries? It is going to be obstructed labor. Okay. Whereas in case of developed countries, the most common cause is going to be your surgeries, abdominal surgeries, and especially your hysterectomy. Okay. Now remember, in case of obstructed labor, a fistula will be forming by ischemic necrosis. Okay. So, there will be sloughing of the necrotic area and then only the fistula will be forming. So, after an obstructed labor, it takes at least 4 to 7 days for a fistula to develop. But in case of surgeries, it is not like that. Okay, either operative delivery or major surgeries like hysterectomy, it will not be like that. It will be right from the very first day of the procedure. Clear? So, this is all about fistulas. Now, yes, we are coming to another important concept. Now, seeing the picture, you will be able to tell me, right? So, what is this picture? This is a prolapse. Prolapse uterus. So, a prolapse uterus can be arising when there is descent of the internal genitalia structures, especially the uterus is descending from its original anatomical position. Okay, so along with the uterus, there can be some other structures, surrounding structures can also descend, and depending upon that, we will be naming each compartment descent. Okay, so anatomically, we can have anterior compartment descent. In the anterior compartment, the upper 2/3 is descending means, then it is going to be a cystocele, and in the lower 1/3 it can be a urethrocoele. And regarding the middle compartment descent, it can be a uterus, right? It can be a uterus with cervix, or suppose hysterectomy has been done means the vault can also come for a prolapse. So, it can be a vault prolapse as well. And finally, we can have the posterior compartment where we can have descent of the intestine, that is enterocoele through the pouch of Douglas. There can be rectocoele as well as it can be a lax perineum also. Clear? Now, see this system of classification of prolapse, and here the point of reference is taken as hymen. Okay. So, this system is Baden-Walker halfway system. Baden-Walker halfway system of classification of prolapse. Okay. So, grade 0 means it is normal. Okay. Grade 0 means normal position. Grade 1 means the descent is halfway to the hymen, and grade 2 means the descent has come to the hymen. Grade 3 means the descent is past halfway after the hymen, and grade 4 means the maximum descent. Clear? Right. Now, let's discuss about the management of prolapse. Okay. So, management of prolapse. Suppose the woman is a young woman, then you have to see whether there is a mild prolapse or which compartment prolapse, like that. Okay. Suppose if there is a mild prolapse, just ask her to do pelvic floor exercise. Okay. And if the woman has anterior or posterior compartment prolapse, then you will offer her pelvic floor repair, and for anterior compartment prolapse, especially when there is an enterocele, you will offer her a surgery called Moshowitz procedure, where you will be obliterating the pouch of Douglas, right? And the next type is when the young female is the one whose family is not completed, but she has a first degree or second degree prolapse. So, in that case, you will have to offer her a sling surgery. Okay, a sling surgery, or you can go for abdominal sacrohysteropexy. Clear? And the final set of young females is one who has completed her family, but she says she wants to preserve her uterus. Then you will offer her Fothergill's procedure or sacrohysterocolpopexy. Clear? Right. Now, let's talk about the elderly women group. Okay. So, in the elderly women, if we do vaginal hysterectomy with pelvic floor repair together, then that is called as Ward-Mayo surgery. This is the one that is offered commonly to these people with prolapse. Suppose if the female has procedentia, then she should be offered vaginal hysterectomy with pelvic floor repair. Along with it, you can even offer her sacrospinous colpopexy. Okay, and if there is a female who is unfit for surgery, then you will offer her something called as Lifforth surgery, that is colpoglacis. Okay, so this is for the elderly females, right? Now, finally, let's also discuss about Now, let's also discuss about the management of vault prolapse. Okay, so vault prolapse. If the female is fit, then you can offer her transabdominal sacral colpopexy. Suppose she is not fit, then you will offer her transvaginal sacrospinous colpopexy. Clear? So this is all about the management of prolapse, right? Okay. Management of prolapse only will be the confusing part. Other things I know you will learn, right? All the grades or whatever it is, the anatomy part, everything you will learn. Only thing, the management will be confusion, and that will be the question for you also. Okay, right. Now, here we'll be saying a genitalia seems like a ambiguous genitalia, right? So, ambiguous genitalia at birth is commonly seen in. So, now let's discuss about congenital adrenal hyperplasia. Okay. See, don't ask me what procedure is done here, why they have kept a catheter and all. So, basically, I think they have done a clitoral reduction here. Okay, we are not going to talk about that. We are going to talk about congenital adrenal hyperplasia and the related concepts, right? So, congenital adrenal hyperplasia is most commonly seen to present as a female pseudo hermaphroditism, and the most common enzyme deficiency is going to be a 21 hydroxylase deficiency. Okay, so female pseudo hermaphrodite means she is a female with the karyotype 46XX and whose external genitalia looks like a male. Male external genitalia. Okay, so Corey, so that's why we are telling it as a ambiguous genitalia. Okay, congenital adrenal hyperplasia or usually autosomal recessive disorders where we have deficiency in the enzymes that are involved in the synthesis of steroid hormones, okay, especially in the adrenal cortex. Okay, and when there is enzyme deficiency, the neonate can present with weight loss, or there can be weakness, dehydration, hypotension, electrolyte imbalances, like that. Electrolyte imbalances can also be seen. Okay, so what happens, there is accumulation of 17 hydroxyprogesterone in these people, and this 17 hydroxyprogesterone are shunted into androgen synthesis. So there is elevated levels of testosterone and androstenedione. Okay, so because of this, the females will have masculinized external genitalia, right? So that's why they have a ambiguous genitalia, and you can diagnose this condition by doing a amniocentesis. Okay, so prenatally you can do a amniocentesis and check for the 17 hydroxyprogesterone elevation in the amniotic fluid, and by that you can diagnose it. And the treatment for controlling this condition is to give steroid injections to the mother, right? So following this, you also have two more deficiency, that is 17 hydroxylase deficiency as well as 11 beta hydroxylase deficiency. Okay, so in 17 hydroxylase deficiency, there will be deficiency of cortisol as well as sex hormones. Okay, in 11 beta hydroxylase, there will be deficiency of only cortisol. And remember, previously I told in 21 hydroxylase deficiency, there is wasting of the electrolytes and there is salt wasting crisis. Okay, they will be going for dehydration, weight loss, like that. But in these two hormone deficiencies, there will be salt retention and hypertension. Okay, however, the most common enzyme deficiency is 21 hydroxylase deficiency, right? Yes. Now, what is this picture? This picture is showing something called as Fitzhugh-Curtis syndrome. Okay, this is a Fitzhugh-Curtis syndrome. If you see, this is seen in advanced pelvic inflammatory disease. That one you have to understand. This is seen where? In advanced pelvic inflammatory disease. Okay, so from the pelvis, the inflammation and the infection is going to spread to the right paracolic gutter. Okay, and there is intraperitoneal adhesions formed. Intraperitoneal adhesions that are formed between the liver capsule. Okay, you are able to see this is the liver capsule and this is the peritoneum. Liver capsule and the peritoneum. Okay, and they are looking just like a violin string. Okay, see, this is like this. Okay, so this is giving a characteristic violin string appearance because of the perihepatitis. Okay, and this will be giving additional symptom to the patient with pelvic inflammatory disease. That is, the patient will be presenting with right upper quadrant pain also. Okay, and this may lead you to suspect cholecystitis or pyelonephritis. Okay, but if she is a female with pelvic inflammatory disease, we have to suspect this Fitzhugh-Curtis syndrome also. And regarding the causative agents of pelvic inflammatory disease, you have two organisms. One is chlamydia and another one is gonorrhea. Among these two organisms, chlamydia is the most common organism to cause pelvic inflammatory disease. Okay, and the discharge that is caused by chlamydia is going to be a watery discharge, whereas in gonorrhea it will be a curdy discharge. Clear? Right. Now here I want you to know about the point of radiation to be given in cervical carcinoma. Okay, you have 2 points, point A and point B. Point A is 2 centimeter above, also 2 centimeter lateral to the external os. Okay, point B is the same 2 centimeter above plus 5 centimeter to the external os. Okay, so that's what you want to know. Okay, so point A is 2 centimeter above the external os and 2 centimeter lateral to the external os, and point B is 2 centimeter above the external os, whereas it is 5 centimeter, 2 plus 3, 5 centimeter lateral to the external os. Clear? Right. And the dose of radiations you will give at point A is about some 7,000 to 8,000 centigrade, and at point B we will give 6,000 centigrade. Okay, so we'll be targeting the lymph nodes present here. Okay, so at point A we'll be targeting the lymph nodes like paracervical or parametrial lymph nodes, whereas at point B we'll be targeting the obturator lymph nodes. Clear? Right. Now let's discuss something about contraception. I am not going to discuss anything in detail. I am going to give you only the difficult concept and I am just going to touch it lightly. Okay. So let's discuss about missing pills. Okay. Suppose if the female misses 1 or 2 pills, then she can be asked to resume the schedule as soon as possible. Okay, that's it. No contraception, additional contraception measures are not necessary, right? And the next one, if she misses 2 pills exactly, you have to see in which week she has missed. Okay, suppose if it is in week 1 or 2, then she can take 2 pills daily for 2 days and then finish the pack. Okay, here also no backup is needed. Okay, suppose if she misses in week 3, then immediately she has to start a new pack. Okay, here you need a backup. Okay, backup not needed, but when she has missed 2 pills in week 3, that time you have to advise her to go for a backup method, right? Suppose if she has missed more than 3 pills, more than or equal to 3 pills, then simply she will start a new pack and backup contraception will be needed. And how long this backup contraception will be needed means another 1 week. Okay, say 7 days. The next 7 days she has to have a backup contraception method. This is about missed pills. Simple, right? So if she misses 1 or 2 pills, then she can take it immediately and resume the schedule. No backup is needed. Suppose she misses 2 pills in week 1 or week 2, then you can take 2 pills daily for 2 days, then resume the schedule. No backup is necessary. Suppose 2 pills are missed in the 3rd week or more than 2 pills are missed in any week, then you have to ask her to take a new pack and you have to advise her to go for a backup method of contraception as well for the next 1 week or 7 days. Clear? Right. Now, so this one is a thing where you have copper in, these are both copper T's, but in this copper T you have copper in the vertical arm alone. So this copper T is copper T 380A. Now let's talk about emergency contraception. The most commonly used drug is levonorgestrel at a dose of 0.75 milligram stat, and this will be followed by the same dose after 12 hours. Okay, and another method of emergency contraception is giving the drug ulipristal at a dose of 30 milligram, and this should be given within 72 hours. Okay, next drug is Centroman. Centroman is given at a dose of 60 milligram. 1 tablet is 30 milligram. So you will give 2 tablets that will be taken twice at an interval of 12 hours. And Centroman tablet should be taken within 12 hours of intercourse, right? And the next one, you can even give conjugated estrogen at a dose of 15 milligram BD for 5 days. Another option is giving ethinyl estradiol at a dose of 2.5 milligram BD for 5 days. And the last option we have is copper T. Copper T should be inserted within 7 days after unprotected sexual intercourse, and copper T should not be given for rape individuals. Clear? Right. Now let's see some of the copper T types. We have copper T380A. Okay, so here A means arms. Okay, copper is present in both vertical as well as the horizontal arms, that is A. And 380 means the total area of the copper used here is 380 millimeter square. Okay, so length of copper T380A is approximately 36 millimeter, and you can use it for 10 years usage. And at the end, if you see, you have a ball, okay, which is round in shape and the size is about 3 millimeter, and this prevents the perforation of this copper T through the cervix. Clear? Right. Now this one is a multi-load copper T 375 which has 375 millimeter square of copper surface area. If you see here, the horizontal arm is not a straight one, but it is an inverted U-shaped one that is made up of plastic, and you have few serrated fins that are present. Each side 5 serrated fins are present. Okay. And in the end, it is not a round ball one like a copper T380A. This is usually a serrated one through which the thread will be passing. Okay. Multi-load copper T is used for 5 years. Right? And the next one is Mirena. Okay. In the Mirena, you have the drug levonorgestrel. Total of 52 milligram of levonorgestrel is placed in the Mirena, and this will be releasing approximately 20 microgram of levonorgestrel daily. Okay. So this is also a T-shaped device. If you see, this is a T-shaped polyethylene frame. So here in this area you have the steroid reservoir. Okay, so that is nothing but you have your levonorgestrel 52 milligram, and finally here you will have a monofilament thread. Okay, so Mirena is also recommended for 5 years. A shorter version of Mirena is Skyla, which is having a small frame, and levonorgestrel is also kept at a low dose, that is a 13 milligram total dose, where it will be releasing 60 microgram daily, and then it will be used for a period of 3 years. Clear? Next one is male condom. Okay, so this male condom is made up of latex, rubber or polyurethane. If you see, one end is closed end and the other end is an open end with an inbuilt rim. Okay, so this can be dry or pre-lubricated with spermicidal jelly, usually nonoxynol 9. Government of India is supplying it free of cost in the name of Nirod. The advantages of male condom is that it protects against sexually transmitted infections. Yes, and this one is a female condom. So this is also made up of polyurethane. You have 2 rings at both the ends, and here also one end is open and one end is closed. This open end lies outside the vagina and the closed end is placed behind the symphysis pubis. Okay, but female condom is expensive and it also needs motivation by the female, right? Yes. Next one is Antara. Antara is also supplied in the government. This is nothing but your depot medroxyprogesterone acetate. Okay, it is included in the National Family Planning Program and usually given by IM route. Okay, the sites of giving Antara injection include deltoid, gluteal region, especially your upper, outer gluteal region, and also your thigh. Okay, remember the site should not be massaged after giving this injection, and it is given at a dose of 150 milligram every 3 months. Okay, as a deep IM injection. 150 milligram means it is present in a 1 ml vial. Clear? Next is Chaya. So this is nothing but your centrocommon. This is also supplied by Government of India as a pack of oral contraceptive pills. In a pack you will be having 8 tablets, right? So this is nothing but ormeloxifene. Already we have seen centrocommon can also be used as an emergency contraceptive, and you have to take 1 pill orally twice a week for 3 months, and after this you have to take it weekly thereafter. Clear? This is how you take a Centroman tablet. Right. Now, seeing this, what you are able to see? Yes, this is a case of cryptomenorrhea where you have imperforate hymen. Right. So, what is going to happen is there is no hymenal opening. So, what happens when a girl with imperforate hymen is attaining her puberty, all the menstrual blood that is coming is going to collect right from her vagina and then uterus, and it is going to extend into the fallopian tubes as well. So, you will have hematocolpos, hematometra as well as hematosalpinx because of this imperforate hymen. Okay, and at puberty she will be presenting with cyclical abdominal pain, and now on examination you will be able to find an enlarged dense bluish membrane that is present in the vagina. Okay, so that means there is imperforate hymen. The management of this condition is by giving a cruciate incision, that is a cross-shaped incision, and letting all the collected blood inside, right? Okay. Yes. Now let's also discuss about the types of hymen. You have imperforate hymen, that's what we have discussed it just now. Then you have an annular hymen or a septate hymen and a cribriform hymen, that is multiple pores are present in the hymen. Clear? Right. Now the next one is transverse vaginal septum. So here from the hymen, the reference point is taken as a hymen. A low transverse vaginal septum is one which is approximately less than 3 cm from the hymen, and a mid septum is one which is between 3 to 6 cm from the hymen, and a high septum is one which is more than 6 cm from the hymen. Okay, and with transverse vaginal septum, the most common complication is endometriosis, because there is going to be retrograde flow of blood that will be leading to endometriosis. Okay, how will be treating this? Yes, you will be definitely giving her a septal resection, right? Yes. Now I just want to discuss with you about some points on screening of cervical cancer as well. Okay, so screening of cervical cancer. See, screening is started after 21 years only. So, less than 21 years, you are not going to screen for cervical cancer, right? So, that point should be kept in mind. And between 21 to 29 years, you can offer her screening by pap smear only. And you can do it every 3 years. Okay. After this, that is by 30 years till 65 years, you will continue screening her by the same pap smear every 3 years, or if she is affordable, you can even offer her something called as co-testing. So, co-testing is nothing but offering HPV DNA testing with pap smear. Okay, if you are doing co-testing, then you can do it once in every 5 years. And after 65 years, please stop screening if none of the tests previously done were positive. Clear? And one more point I have to add additionally is, suppose if you get a negative pap smear report and then if you want to test it by doing HPV DNA test, then that is called as reflex testing. So, co-testing is something where you do HPV DNA and pap smear together. Okay, and reflex testing is where you do HPV DNA test after an abnormal pap smear report. Okay, and usually HPV DNA is not offered to females for less than 30 years because in these age group, transient HPV infections are common. Okay, so that's why we are not offering HPV DNA test less than 30 years, right? So yeah, this is all about gynecology. We are done with the session and my expectation is that this session will work effectively for you. So until we meet in a similar session for obstetrics discussion, stay tuned, happy learning, keep going, take care and bye-bye.